behalf of our team and behalf of our collaborators, thank you for being here and welcome. We are excited today to talk a bit about raising awareness, what we think are reasonable things that doctors and healthcare providers need to know about misophonia. We're going to walk through some slides and orient people to this, but before we do, just a couple of kind of ways to think about how to be in this context. So we've got everyone muted and appreciate people staying on mute in order to kind of minimize distractions. We'll do everything we can on our end to do the same. I'll do everything I can to not unintentionally trigger anybody in anything that I do. If I do unintentionally trigger you, I apologize in advance. I am somebody who is super sensitive to misophonia. I live with a family member with misophonia, and I do my best, but I may not be perfect at it all the time. So today's focus on raising awareness is going to start with a presentation, and then what we'll do is we'll try to wrap up around 30 minutes after the hour, and we will then use time from there to do kind of a live Q&A. So if you have questions along the way today, please do ask your questions in the chat for the Zoom. And when we finish with the presentation, we will stop recording, and then we will begin answering the questions. Along the way, as you ask questions, Cris Edwards, who's so graciously here from soquiet.org, will be answering questions on behalf of all of us. So feel free to ask anything to Cris, who, as many of you know, is one of the leading advocates in the world for misophonia, and is a great collaborator of ours that we really appreciate being here to help us out with today. Okay, so I want to also acknowledge that we wouldn't be here and we wouldn't be doing anything that we do at Duke without anonymous donors. We have an anonymous family who provides the base of our financial support, literally paying for our jobs and portions of our jobs to be here. Without them, none of this could happen. And we also have a number of smaller anonymous donors that do the same thing. So we just want to really extend a heartfelt thank you to all of the donors. And our most recent largest donor is the Brown family, who has provided funding for us to really work hard on advocacy and outreach and education. So thank you to the Brown family. And we really wouldn't know anything we know or be able to do anything we do without all of the brave families and patients and research participants that we talk to on a daily basis about misophonia and about their experiences. So thank you to everyone, to our collaborators, and to our team here at Duke, and especially to Grace Peppis, who's here with us on video and is our CMER Outreach and Education Coordinator, and literally made most of these slides. I'm going to give Grace all the credit she deserves for organizing this presentation. Thank you, Grace, and thank you, everybody. Okay, so this presentation is designed to help you as patients, you as family members, you as sufferers, and if you are a provider, a doctor or other healthcare provider, this presentation is organized for you. And the idea here is we really want to try ultimately to make it the case that any person who goes to see any pediatrician or any primary care doctor or any specialist who has misophonia, we want their experience to be one where the doctor, healthcare provider knows what misophonia is and is validating of that person's experience, and then is able to resource them and offer them the kind of help that might be useful. So this presentation is really organized to try to raise the bar on that level. And as I mentioned earlier, we are recording, and we will post this to our Duke CMER YouTube channel. And you can access this, or anybody in the future can access this presentation for free. We really value everything being free and not charging people for things. We want the word to be spread. We want people to really absorb the information, to process it, and to share it with their healthcare providers and with each other. So what do we think doctors need to know and people need to know first. And the first thing is that misophonia is real. It's a real thing. It's not a thing that's just made up. It's not a thing in someone's head. It's a real thing. It's a real problem with real consequences that at this point now we can say, roughly 12 years after the first scientific study of misophonia, there's actually a pretty good science emerging that is describing and documenting what misophonia is. And this is only continuing, and it's really, really exciting. But the takeaway here is misophonia is real. It's a real thing. It is a prevalent problem, and we're going to go through all of these things in more detail. It's a prevalent problem. I'm going to give you statistics to share with each other and with your doctors on the prevalence. We're going to talk about how problematic it is. We're going to talk some about how to define it. So what really is the consensus definition for what misophonia is? We'll talk about that. We'll review that. We're then going to talk some about best clinical practices that we recommend doctors and healthcare providers follow, and that we recommend you ask for and you look for as consumers of healthcare. So this is kind of how things are organized. So first, thinking about how real is this? Well, we recently did a review of the scientific literature, and as of now, there are roughly 250 studies published about misophonia that are listed online. And if you're not sure how to see these things, all you need to do is go onto Google, type in the word scholar, hit enter, and now you are in the world of scientific research, and you can type in the search bar misophonia. And you will now see at least the abstracts, the titles. You'll see kind of the overview of all of the research that's ever been done on misophonia. And if you are wanting to nerd out like I do, and my team does, you can read away all you want and read and learn and do as much of that as you want to. There's also advocacy groups now that have done really important work all around the world. So sometimes people ask us, is misophonia something that is only in the US? Or is this only something that is part of the Western world? And we can say definitively that it is not simply an American phenomenon, and is not simply a phenomenon in the Western part of the world. This is a global phenomenon. It's a real problem that we see across the world. And this map that we've got for you here visually to look at, what this map is just showing you is sort of a visual example of what I'm saying. The dots here on the map represent places in the world where our team at Duke is currently collaborating with researchers studying misophonia, or collaborating with advocacy groups to better understand and support people with misophonia. You can see there is a lot happening all around the world. Not everywhere, but it is growing and it is spreading. And I think actually, even since we made this slide, we've got additional collaborators in France and Germany that will be populated on the next version of this map. Misophonia is prevalent. This is not a rare disorder. Even though if you go online and you type in misophonia, you might see wrong information that comes up in your Google search. It might say at the very bottom, this is a rare condition. But I'm here to tell you, this is most definitely not a rare condition. Let's look at the numbers. So 4.6% of adults in the US have clinically elevated levels of misophonia. And this is a study that was just published. And it is to date the single largest study ever done on misophonia. And it is a study that used a type of sampling approach that basically representatively samples the whole United States. So it's not just a sample of certain kinds of people. It's really a population level, 4,000 plus size study looking at all of the US, urban and rural and different race and different ethnicities and gender and so on. And the answer they came to is 4.6%. And they used a fairly stringent definition of misophonia. In Germany, we see a similar type of really rigorously done population level study, and they found in two different studies, two different groups found somewhere between a 2 and 5% prevalence estimate. In Turkey, they used a type of household style sampling strategy, a little bit smaller of a sample, a little bit less stringent of a threshold, and they found 12.8%. Now, if you think about this, and you might have seen, some of you have been online and you've looked and you'd say, oh, well, there's studies that found 20%, 18%. I am telling you that what we think as scientists is that the really carefully done scientific research, like the ones I've got on the screen for you, they're going to show estimates lower. They're going to show these estimates closer to what you see here. The studies that have shown something like 15%, 20%, there's one study that found 50%. These are overestimates in all of our minds. These are overestimates because they're not using a stringent criterion. They're kind of saying, how prevalent is it that people are bothered by sounds, not clinically impaired in a significant way. Now, these studies on this screen really use that more stringent criteria. The short version of what I'm saying, guys, is this is probably the most accurate. This is probably the most scientifically responsible and accurate prevalence estimates you're seeing here. It's probably closer to 2% to 5% than it is to 15 or 20%. You might be thinking, oh, well, I thought it was much more prevalent than 2 to 5%. No, 2 to 5% is hugely prevalent, hugely prevalent. By comparison, misophonia using that 2 to 5% prevalence rate is more prevalent than many, many other disorders that we all commonly hear about and talk about, and that people study and that the government funds to study. And these on your screen are just a couple of examples. You look at the prevalence rate, for example, of autism, and it's around, if not much lower than misophonia. Obsessive compulsive disorder, schizophrenia, anorexia, borderline, and so on. There's many other examples. The point here is that the prevalence rate of misophonia is high and it is most definitely not rare. The next thing your doctor needs to know is that misophonia is problematic. Problematic in the sense that this is not simply being bothered, this is being bothered in a way that is far beyond being bothered. This is where impairment in relationships, impairment with family, with friends, at school, at work, this is what defines misophonia compared to kind of just being very, very bothered or annoyed easily. Similarly, the symptom severity level is much higher in misophonia when we call it misophonia, right? It's high anger, rage, panic, intense distress, avoidance behaviors, escape behaviors, frequently being triggered, intense reactions, right? So misophonia is not simply just being bothered. In a way, you can teach your doctors and you can teach people about this. It's very, very simple. I think it's actually very simple. Just like most people have anxiety at some point in their life, most people don't have an anxiety disorder. Just like most people actually have traumatic events happen to them in their lives, most people don't therefore develop PTSD. Similarly, you can describe this as saying most people are bothered by some sounds. Most people have some kind of sensitivity to noises. But most people are not people with misophonia. So this visual on the screen gives you kind of a visual way of understanding what I was just teaching you, right? That if you imagine noise sensitivity or sound sensitivity as a kind of like a trait in the human population that's distributed on a normal bell curve, like what you see here, most people are probably somewhere in the middle of this curve where they're kind of sort of bothered or not very bothered, but they're not on the tail ends. Misophonia is probably what we see on the tail end of the distribution. So similar kind of argument you can make for something like depression. Most people have times when they feel sad, right? That's common, that's ordinary, but that's not depression. Right? You could use the same arguments perhaps with substance use, like alcohol use. You could say a lot of people might drink alcohol, but that doesn't mean that they have alcoholism, right? So the point really here is this is an extreme on a spectrum. This is not just simply being bothered. So our consensus definition of misophonia was published several years ago, and this is accessible to you online if you want to read it. You can do exactly as I said a few minutes ago and go to Google Scholar and type in consensus definition of misophonia. And what you'll see is this. You'll see this paper. And in this paper, a group of experts got together and essentially just kind of spent a good year meeting and voting and going through in a systematic way how to define misophonia based on what had been published already. And this is what we get. It's a disorder of decreased tolerance to specific sounds or stimuli associated with such sounds. Stimuli are often called triggers, and they're very distressing, evoking strong negative emotional, physiological, and behavioral responses that we wouldn't expect to see in most other people. Individuals with misophonia might have a range of negative emotions, but anger and irritation, disgust, and anxiety seem to be perhaps most common. Triggers elicit a really strong increased arousal in the body, what we call autonomic arousal. So this can be any number of things like muscle tension, heart rate, or sweating, or anything like that. And the reactions to these triggers cause significant emotional distress and interference with everyday kinds of functions. Okay, this is kind of your definition of what misophonia is. And again, you, if you're a doctor, now you know this is how misophonia is defined. If you're not a doctor, now you know you can hand this to your doctor and tell them this is how it is defined. Okay, so sorry about that. So another point on this is that misophonia is not technically a medical diagnosis yet. More on that in the next slide. But we can think about it as the presence of one or more trigger sounds eliciting an intense emotional response. And critically, really critically, misophonia responses are to cues irrespective of how loud they are. So if you are responding to sounds only because you experience them as louder than everybody else around you, and loudness is really the thing that's most upsetting, and loudness is the thing that's most impairing for you, that is not what defines misophonia. That is more like what we call hyperacusis. So in misophonia, the triggers can be loud, but they also can be soft. So the perception of volume is not what defines misophonia. The trigger sounds evoke these big reactions that are out of proportion to the circumstances, right? So somebody's breathing and there's a reaction, even though they're really just breathing, but the reaction is a very big reaction. Or they're eating, they have to eat. They need to eat. Eating is a biologically necessary thing, but the reaction is really kind of out of proportion to what the person is doing. Active avoidance, discomfort, the need to escape or block or avoid, the sense of loss of control, and the persistence of this over time. In other words, not something that happens once or twice, but this is a consistent, at least for several months or more, we might say, it's starting to sound more like misophonia. So these are kind of like criteria that have been suggested as possible diagnostic criteria if and when misophonia is officially a diagnosis. The good news on that front for you and to share with your doctors is that there is now an ICD-11 proposal to include misophonia as a distinct diagnosis. This is new. This was several weeks ago, and I am really honored to say that I'm part of a group that put this proposal together, and we submitted this proposal, and it is now under review with the ICD. ICD is the manual that's used worldwide, not just in America, but worldwide. And it is for all medical health problems, not mental health. It's for all medical health problems. This is the World Health Organization-driven manual for understanding, diagnosing medical problems all around the world. So we decided, we being our team of people that proposed this, which includes scientists, clinicians, and critically, a number of people who experience misophonia in themselves or who are loved ones of people with misophonia, we collectively put this proposal together, and we decided we thought it made sense to do this to the ICD and the World Health Organization instead of the DSM for those two reasons I already mentioned. The DSM is a mental health document. The ICD is an all health document. We want all doctors to know about misophonia, not just mental health doctors. And the ICD, again, it's a global document that the whole world uses. The DSM is only really used here in the United States. So we want misophonia to be something that's understood globally by all doctors. That's why ICD. So if this proposal is accepted, what it would mean is that doctors would be able to formally diagnose misophonia, and we think this will also help increase awareness and allow doctors to be able to reimburse, to be reimbursed for diagnosing misophonia and helping people with misophonia. But we're absolutely just delighted that this is under review, and we are crossing our fingers and doing all of the superstitious behavior we can to hope that this actually gets approved. And we should know hopefully sometime in the spring if it looks like it's going to move forward any further. If it doesn't, we won't give up. I can promise you that. Okay, so quick tip for you guys as patients or parents. This is something we tell parents and patients very regularly. When you're looking for a provider, you don't have to always ask for an expert on misophonia. In fact, you might be doing yourself a disservice by doing that. Instead, we actually recommend if the person you're contacting does not advertise as they are a misophonia expert, which let's face it, that's almost all healthcare providers, what we recommend is that instead of asking for misophonia, you instead ask for help using more descriptive language. Not a diagnosis, but more descriptive language, like what you see on the screen. So you say, my son, my daughter, or I am having problems with over-responsivity to auditory triggers. I'm having strong emotional reactions. It's causing a lot of problems in my life every day. It's really upsetting. Can you help me? Right, so just describe it. It's a little bit more words, but we think you're more likely to get a response from a provider and more likely to get listened to and get help versus if you contact them and say, I need help for misophonia. Right? They're very likely to say, well, I'm not an expert in that. You need to call the expert. But the truth is you don't necessarily always have to find the expert. And the other truth is we know there's not a lot of experts. So this is a strategy for now that we recommend. And I hope to report back in a few years, we don't have to use this strategy. There are enough quote unquote experts. So what should your doctor do? And doctors listening, what can you do? What we recommend as best clinical practices is sort of a model where all providers start by listening. Really listening carefully for misophonia and for screening misophonia. And if the screening is positive, that they can refer to specialists, or if they are a specialist, they can then assess more closely and then treat or refer. So we recommend doing this in a little more detail this way. So providers should be listening, and you can think about this if you're a loved one listening, this is for you as well. Listen to what the person is telling you about what triggers them and what happens when they're triggered. When they're getting really angry, when they're getting really irritable, when they're getting really upset, what is it that's causing them? Ask questions and listen. And ask them, what are the reactions you're having? And how is it getting in the way of your life? Are there problems with friends, with family, at school, at work, and so on? Doctors can ask, are these responses related simply and only to the volume of the sound that you receive? That will, as I said, kind of tell us if it sounds more like hyperacusis. And do you respond to everybody making sounds or just certain people? Most commonly in misophonia, it's certain people. It's not all people. It's certain contexts, not all contexts. And we want people to be validating, to listen, to be supportive, to be reassuring, to let people know they are not alone. This is a real thing. And that people are studying it and people are learning how to treat it. And there are ways to get help, even if there isn't a cookie cutter perfect way for everybody instantly to get there. That doesn't exist, by the way, for almost anything. It certainly doesn't exist yet. So a little deeper here on screening. There's a couple of screening measures that have been recently published in the last few years. In fact, this child and adolescent misophonia screening list here on the screen, the child and youth version, was just recently published by the Amsterdam Research Group. So this is a new screening tool that can be used with kids and teenagers to screen for misophonia. It has very reasonable kind of statistical support behind it. There's an adult screening tool, the Duke Vanderbilt Misophonia Screening Questionnaire. You can access these things online. You can, again, go to Google, type in Scholar, look this up, and you can get it. You can get the measure, you can hand it to your doctor if you need to. If a screening shows it looks like there might be misophonia, the next step is to go a little bit deeper with a deeper assessment. And for child and adolescent patients, we might recommend either of these two measures, the Amsterdam Misophonia Scale Youth version or the Sussex Misophonia Scale for adolescents. These are two of the early measures with some statistical support, and they can, again, be used to get a little bit more clear of a sense, a little bit more comprehensive of a sense of misophonia severity than if you just use a screener alone. And for adults, there's a bunch more versions of these kind of deeper assessments. We've listed the ones below here in alphabetical order. We created the Duke Misophonia Questionnaire and the Duke Misophonia Interview. Our colleague, Marta Siepsiak in Poland, created the MisoQuest, which is a very short, excellent version of a type of assessment. And our colleagues, Celia Vittoratu and Jane Gregory, and their colleagues created and validated the Selective Sound Sensitivity 5-factor model. Just call it the S5, which is really the self-report measure that has the most scientific support behind it to date. So there are tools now, and guys, a few years ago when we were doing these webinars, we've been doing these webinars for 7 years now, and a few years ago, we couldn't say any of this stuff on the screen. I mean, this stuff is really advancing rapidly. In terms of treatment, treatment should minimally include these basic ingredients: education, support, empathy, validation, parent and family involvement, supportive resourcing with information that's credible. We recommend SoQuiet.org as a really scientifically responsible advocacy organization to turn to for evidence-based kind of information. We recommend multidisciplinary referrals, and that these referrals to different disciplines are really based on every single patient getting what they need. So not the same kind of cookie cutter approach for everybody, but some patients need a neurology referral. They have really bad migraines. Some patients have really bad kind of sound sensitivity more generally. Maybe they have tinnitus or hyperacusis, right? They need to see an audiologist for sure. A lot of time we see kids who have multisensory sensory over-responsivity, at least as reported by their parents, or we see adults with this, where they're sensitive to sound, yeah, but also to touch, to smell, to taste, and so on. Occupational therapists are excellent providers to turn to for kind of a multi-sensory over-response. So the idea is that best practice is to really provide the best referrals to each patient. The reason for this is that misophonia is not it's not a disorder that lives in a specific discipline. It really is a disorder that lives at the nexus point, that intersection of multiple different disciplines. So we think multiple different disciplines should be helpful in assessing it and providing treatment recommendations. And you can see examples here again. Audiology, why? Well, because this is a hearing-related disorder. It's not just a hearing-related disorder, but hearing is related. So audiology is a really appropriate evaluation referral to make. Mental health is a very important referral source to turn to for the reasons on the screen, that mental health providers, which I'm a clinical psychologist, we know how to use evidence-based approaches to change behavior, thinking, attention, what's going on in the body, emotion, motivation, and how people communicate. So these are all things that are relevant to people with misophonia. So mental health providers need to be considered. We talked about occupational therapy already. And a thing to know is that there are co-occurring disorders across misophonia, across different disciplines. So people with misophonia might or might not have other hearing problems. They might or might not have mental health problems. It's variable and it's very patient specific. Everybody's different. Everybody's different. So a multidisciplinary approach allows you to really do all of this. And again, doctors, if you're listening, we want you to be coordinating with the specialists. And specialists, if you're listening, we want you to coordinate with primary care and coordinate with pediatrics. We want a team, we want a care team to provide the kind of support from a multidisciplinary perspective that people need. On the mental health side, there's no single specific gold standard treatment yet for misophonia, but that does not mean we can't help. It does not mean we can't help. It just means there isn't a single one specific cookie cutter type thing that we think everybody should have. That isn't there yet. What we recommend instead is to follow the growing science on misophonia, and we can help you with that. This is what we do every day. We try to help people understand how to make sense of the science of misophonia. And it's an underlined kind of big word here on the screen, but the word is transdiagnostic. What do we mean? We mean we want you to find mental health providers that use approaches that can help across different diagnoses. We don't want you to find mental health providers that only do one particular treatment approach for one particular disorder. We get worried that that will look like having an overly constrained, narrow-minded approach that may not work for everybody. So you can look for people that use this fancy word, transdiagnostic. In the mental health world, this is just a word that mental health providers know. Right? So how can they help you or your loved one change their attention, their thinking, their behavior, their communication, their physiological responses, using evidence-based approaches? This is the kind of strategy that we recommend. Evidence-based, meaning reasonably supported by science. Not made up, and not something that's just someone's opinion, and not something someone just thinks they should do because they heard it might work on Instagram, right? But like something that's got some reasonable, credible, scientific base underneath. Okay. And the unified protocol I list here is just one of those. It's not for everybody at all, but it is one example of a type of evidence-based transdiagnostic approach. Well, you might say, well, I've looked and looked and I can't find providers that know how to do really specific treatments for misophonia. What I would say is that's okay. That is okay. What you need are providers who can help you or your patient identify basic patterns. Patterns. Let's talk for a minute about patterns. So in misophonia, there are patterns. Everybody has patterns, right? I have patterns, you have patterns, we all have patterns. Humans are creatures of patterns, right? We do things over and over and over again. Things kind of just continue to happen in different contexts in similar ways. So what are the patterns? And this is a grid we use clinically in our clinic here at Duke. And you can access this on our website if you're interested. You can see the link here on the side. What this does is it helps identify before being triggered, while being triggered, and after a trigger stops. What are the patterns that happen behaviorally, attentionally, somatically, interpersonally, cognitively? And this becomes a grid that can build insight into knowing what it is to try to change. Lots of providers can do that work. Lots of them. You don't need an expert to do that right there. What you can do is you can ask your therapist or ask a healthcare provider, are you able to identify patterns underlying misophonia? And do you think patterns are different across people and contexts, or do you think all patterns are just the same for everybody all the time? And do you think you can help prioritize patterns based on what I, as the patient, am willing or able to work on, and like what's most important to me among my patterns? And by the way, do you think you can target those patterns using interventions that are likely to help me? Where likely to help me means like there's some modicum of science behind it, some reasonable, even low level, there's something saying that this thing might be a treatment that can help me. So we recommend literally asking potential clinicians if this resonates with them. And if they say yes to these things, there's a good chance they may be able to help. If they say no, they might be a bit more narrow. They might say, well, I only do exposure therapy. Well, guys, there's your clue. That might not be who you want, right? If that's what they say they do and only do, that's pretty narrow, and that's not a very well-received treatment for most people with misophonia. So that would be a bit of a big red flag. But if they tell you, I use evidence-based approaches, I know there's not one treatment, but I really try to figure out what will work best for you or your daughter or your son. And we're going to figure out what the patterns are. And we're going to try to figure out which ones to prioritize. And we're going to kind of figure out which treatments to use based on what to prioritize using science as a backdrop. This is somebody that we can work with. This is somebody you can. So doctors, again, and healthcare providers also need to refer. We talked about multidisciplinary. We've talked about evidence-based practices. We've talked about not having to be experts in misophonia. A thing you can look for here as parents or sufferers is look for the audiologist who specializes in decreased sound tolerance. So not any old audiologist. You don't need a normal hearing audiogram, right? You need somebody who knows how to test for decreased sound tolerance. And similarly with mental health, you want somebody who can treat co-occurring problems in a really flexible way, not somebody who has a hammer and all they see are nails. You want somebody who's flexible. I know a lot of you know this already, so I don't mean to be preaching to the proverbial choir here, but we know in our privileged seat here just how much people are unfortunately taken advantage of out there. There's a lot of kind of snake oil stuff that's out there. And we're not going to name names or name treatments. We're not going to disrespect in that level. But we want to encourage you to be really critical and really thoughtful. We want you to really understand that if you're feeling desperate, you are vulnerable. And we want you to understand that and really try, despite feeling desperate or being vulnerable, to not just believe anything anybody says because they say it. Right? We all know examples of people telling us that they have something to sell us and it not actually working very well. So we hear some pretty awful stories here at Duke about these kinds of things, and we just don't want this to happen to people. We want, if nothing else, patients to experience no harm when trying to receive treatment. So be careful. You can reach out to us anytime to talk about this, to ask us questions. We're happy to meet and talk more about this. This is a really heavy, heavy topic, and nothing can be more heavy than losing a loved one. And we want to end the presentation here on this note that beginning next year, there will be World Misophonia Day on July 9th in honor from the request of the Del Val family, just to honor their wonderful daughter who tragically passed away from taking her life at the age of 17, and she suffered tremendously from misophonia. And this is it's a very, very heavy thing and hard thing to, even for me to talk about it. It's very heavy. You can share her story to help raise awareness with your doctors and the people around you. We can honor Michelle in that way. Okay, so before we turn to Q&A, just want to pause here and invite anyone who's interested to join us in, what is this, Grace, 6 weeks from now, January 24th. We're going to do our annual year in review. We've done this the last few years, and it's kind of fun, actually, to sort of pause and recognize the top advancements in the year. If you're curious, on our YouTube channel, you can find it online easily. Just go to Google, type in CMER, Duke CMER Misophonia, or YouTube CMER. You'll see our webinars from 2022 and 2023 reviewing what were the biggest advancements in those 2 years. And now we're going to do 2024. We have a few ideas, but we also want to know what you think. We'd love for you to share. We value everybody's input. We really want input. Grace has asked for input recently on our @Duke Center for Misophonia Instagram channel, which if you're an Instagram person, please follow us at Duke Center for Misophonia. Please follow us and please share that. We really appreciate the messages we get and the resources that we offer. We like to offer resources that are evidence-based. And so we've asked people on Instagram to share what they think are the top 10 advancements. We want to know from you too. Go ahead and email us. What do you think are the most important things? And guys, with that, I'm going to stop sharing screen. I want to ask us to stop recording, and then thank you all for listening, and thank everybody on YouTube in the future from right now who's listening. Thank you for everything you all are doing to support everything we're all doing in the misosphere to help people with misophonia. Thank you, everyone.